Welcome everyone. Thanks for joining us at this EPPIC webinar, EPPIC Global Presents Ask Me Anything webinar series. This is our second webinar on COVID-19, and we have a great speaker today and a great program lined up for you. Next slide. So I'm Amita Joshi, and I'm the chairman of EPPIC Global. I started in my chairperson role. I've been on the board for a few years. So I'm here to welcome you. Next slide. And here is the agenda. We will we will have Nirav Shah, MD, MPH, who will tell us a little bit more about the new tools for the new times that we are in right now with COVID-19. So he'll have prepared talk with slides, and then we'll go into a Q&A session that Sanjeev Redkar, another board member of EPPIC, will moderate. And then we would like you to stay on to hear a little bit more about EPPIC and how you can become a member, because we plan to host webinar series as we are doing shelter in place right now. Okay, next slide. So a little bit about EPPIC Global. We were founded in 1998 by professionals who are in the pharmaceutical, biotech, and diagnostic area. And over the years, we have actually extended this to medtech and digital health as well. So the professionals who participate are from a very wide range of industries in the Bay Area. And the focus is networking, entrepreneurial opportunities, and mentoring. So this is what we have been focused on in providing a forum for all these three activities. Our goal for the next 2-3 years is to be the leading forum for healthcare and life sciences, with a focus on the theme where technology meets healthcare. And as we live in the Bay Area, we felt this is the right kind of focus for us to have. And so that's where we are headed. But we had to take a little pause because given we are in shelter in place and with COVID-19, we wanted to figure out what we would be providing to our members and as a service to the community. And what we have decided is we'll develop programming that will help understand the science behind this virus, make sense of all the data that's available. And as everybody is, we just overloaded with all kinds of data and news that we hear about it. And we want to reassure that science will triumph, and that we will have, in due course, something that helps us understand this better and get out of this this space that we are in. And so we have decided that we are going to offer webinars to support this goal. And so this is our second webinar. Next slide. So a little bit history again regarding EPPIC Global. In the past, we have offered full day conferences, and we have always been true to the time, and they have been very timely for whatever is going on in the industry during that time. In 2017, we focused on immunotherapy, bioinformatics, and devices. In 2018, we did a whole day session on where technology meets healthcare. In 2019, we pivoted to talk about personalized therapies, and in particular, cell and gene therapies. And so this year, next slide. So this year, this is our second webinar regarding COVID-19. And members who participate will be able to view some of these webinars in a protected environment. And so we are very happy to do this again today. Next slide. So here are our board of directors and executive committee members of EPPIC, and we have a very highly engaged team that is working to bring you these programs. And we would love to tell you more about EPPIC, and you can follow us and become a member. And we are currently working on our operational plan that Robert will tell you about at the very end. So with that, I will hand over to Sanjeev, who will introduce our speaker.
Thank you, Amita. It is my distinct pleasure, honor to introduce my friend, Dr. Nirav Shah, to this first webinar series second webinar series that we are doing. Dr. Shah, I mean, he has an amazing background. Currently, he's a senior scholar at Stanford School of Medicine. But unlike all of us, he brings a very different experience to the table. Not only comes with an illustrious educational background, with a bachelor's from Harvard in biology, medicine from Yale School of Medicine. But subsequent to that, he worked in New York as a commissioner of New York Department of Health, so in the public health system. He was the chief operating officer, clinical operations at Kaiser just before making Bay Area his home. So he brings a very unique skill set in this discussion. And currently, he's also a member of the Health and Human Services Secretary's Advisory Committee on National Health Promotion and Disease Prevention for 2030. It is an active committee that is managing, and it is so relevant in the current context that we are in. Met him about a couple of years ago. He has graciously agreed to share his thoughts. It is again my distinct pleasure to welcome Nirav into the EPPIC family here. And Nirav, please, we'd love to hear from you. The format is he'll be presenting his thoughts for the next 15 minutes or so, after which we plan to have a 1-hour Q&A session, in which I really appreciate the questions that everybody has given us. Those are the questions that we'll be addressing. Nirav, over to you.
Thank you so much, Sanjeev. It's really a pleasure to be with EPPIC Global, and thank you, Amita, too, for having me. I am really excited about this conversation. I've been giving it a lot of thought, and I hope it's useful, and I know I'm going to learn a lot from you. I've seen some of the work that you've had presented in the past, and some of it makes my head hurt. It's really complex. You are a serious group diving deep into the science. You're not afraid of the truth and the depth of knowledge that's required to really make sense of this. So what I hope to do over the next few minutes is to talk broadly about what we need to do to reopen our society. And as we do that, what do we have to think about? What are the metrics we have to look at? And what I've tried to do is prepare a few slides to help organize that conversation. So there'll be plenty of time for Q&A afterwards. Feel free to put in questions as I'm speaking in the little Q&A box, not the chat box, but the Q&A one, and vote them up or vote them down, depending on your interest in the questions. And we'll try to address the ones that are most voted up first as we get to the Q&A section. So I'll start by talking about what are some of the things that you should be watching and have a good sense of as we talk about reopening our economy safely. There is going to be a lot of differences in what we mean by safely, whether you're in Georgia and apparently was safe enough to open up the economy, and just about every business is essential now in Georgia as of last Friday, a week ago Friday, actually 8 days ago, versus in Santa Clara, where we are going to be on lockdown for another month with a modified stay-at-home order. So these are some of the things I want everyone to have a clear understanding of by the end of the next 10-15 minutes. Let's start with RT. Now you've heard of this, you've heard of it as R naught, RT, R effective. There's many different ways you may have heard of it. It's essentially how infectious is the virus that causes COVID-19. And we know that the COVID-19 is unlike many other viruses like the flu and other prior SARS viruses in that it is much more infectious. It has a much higher RT than other viruses. And unfortunately, not only does it have a high RT, it also has a high morbidity rate. For those who it affects, it can affect them pretty badly. Today, the best of our knowledge suggests that almost half of the people who have it are asymptomatic carriers. That means a lot of transmission is happening in the first 5 days from people who don't even feel sick or aren't showing symptoms and claiming to be sick. So maybe they have something small going on, but they haven't thought about it as being ill. And during that time, they're actively getting more people infected. Another 40% are symptomatic. 10% is environmental. So that's spread from a handle at Costco or a doorknob at a very widely used store where a lot of people are touching the same doorknob. And then a final small percent is beyond that. But let me go into the details about that RT first. So let's start with, this is Nevada. Nevada is opening up. And what is their RT? This is a real-time graph of what their RT, the infectious rate of COVID-19 transmission in the community has been over time. Now, we know that it ranges between higher than 2 when there's no shelter in place, no stay-at-home order, no mask, nothing is happening to slow down the spread. It can spread on average 2, 2.5, 3 even persons for each infected person, right, per day. And what we're showing here is that when the infection rate goes down to the 1 range, that means it's in the linear growth range. For every single person who's infected, they're infecting 1 more person on average. When it's less than 1, 0.9, 0.8, that means over time, the infection will go away if you stay under 1. And that's the whole goal, is all of our different things that we're doing, wearing masks, stay-at-home orders, ultimately with herd immunity and other things, we will get the effective R down to a point where we won't have infectivity and broader spread. So our goal is to get it below 1 and stay under 1. This should be one of the first gates that you think about when you're thinking about, are we ready to open? Is Santa Clara County, is California, is Nevada, is Georgia ready to open? You have to look at the RT. And there's many sites that do it. I am a proponent of this covidactnow.org website, where a lot of this data is presented. I am one of the unpaid advisors to this all volunteer site, which took the model, the SEIR model, the standard models from Harvard, and worked with Georgetown to put them up on the net. They have the most transparency of any of the models out there and continually updated. It's a bunch of Bay Area technologists, Facebook, Google, and other startup folks, scientists who've put this together. And so I'm biased. Again, it's free. India used this to lock down 1.2 billion people. They just downloaded the stuff off the COVID Act Now website and put in their own numbers. And so I am biased, and I like this website. So I'll push you all toward looking at that. So certainly RT is going to be very important as we think about, are we ready to open? The other thing that we haven't really had to worry about here in the Bay Area, but certainly New York, Detroit, Louisiana, other places had to worry about, was health system capacity. Are we going to overrun our hospitals because we'll see a surge of patients all at once, getting sick, needing oxygen, being admitted, and taking up the few ICU beds there are? And so that's, again, something that's modeled down to the county level. This is from 2 days ago in Orleans County, New Orleans, Louisiana, where we know they were at this point in the black, well above their capacity, and had were stretched too thin. But with the lockdown orders, hopefully in the next week or so, they'll come down to a more manageable level. Obviously, if they opened up their economy and started not sheltering in place, the backsliding is shown in red. So hospital capacity is another important metric that we have to think about in the background. Perhaps after this first wave, we will be better appraised of the possibility of backsliding, and we won't need to get against that hospital capacity, ICU bed capacity, but it's something you should always be tracking. The next I'm going to spend a little time on is testing capacity. And this is really important because when we talk about testing, it's easy to get confused. There's so many tests out there. Which ones are good? Which ones are bad? Should I get one? Do I need to wait? Is it not reliable yet? All of these are questions that you should have, because I still have them too. And when we first started to talk about testing, what we talked about was, are you currently infected with COVID-19's virus? And are you potentially going to infect other people as a result of being currently infected with the virus? You may be asymptomatic, you may be symptomatic. Either way, it's a PCR-based test. The most common one was a nasal swab, a plastic nasal swab that goes in through the nose, in the back. And you've heard of the drive-through testing that Google and Verily set up, that Stanford and many others have. That's the PCR test to see if you're actively infected with the virus. And so they're catching virus, live virus from the back of your nasopharyngeal cavity, and then using a PCR test, which has about an hour and a half turnaround time at the fastest. generally about 12 hours turnaround time. Otherwise, that's the one that we're talking about mostly when we're talking about testing capacity. And so until now, we were only testing those at the tip of this iceberg. This is the people who were coughing, who had a dry cough, who had fevers, who maybe lost their sense of smell, lost their sense of taste, who needed to be admitted to the hospital with rule out COVID. All of those people were the ones we were testing. And when you test those where you have high suspicion, a large percentage of those tests are going to be positive. Conversely, a large percentage of those tests are going to be negative if you test everybody. So if you go broad, if you go down this pyramid, down and add more people who have mild symptoms, no symptoms, broadly test everybody like they're doing in South Korea, then your rate of positive tests of people who are active with COVID-19 today will go down. This is very important. So when you look at different countries, it's a little hard to read. I'm going to send all the slides, which are actually very readable, to the organizers to distribute to anyone who wants them. You'll see that for most countries, like right now, US is in the middle of this red circle, right in the middle. And we are here. We have way too many cases. We don't have enough testing capacity, and we are absolutely nowhere near testing enough people just about anywhere in the country, with a few exceptions, right? You look at the New Zealands of the world, the Taiwans, the South Koreas, the Vietnams of the world. They are testing everyone all the time, and that leads to a very different result. So this is an example from South Korea. This is from the website from Thomas Pueyo. If you look down here, Thomas, T-O-M-A-S, Pueyo, P-U-E-Y-O. I would suggest that his 3 blog posts are required reading on Medium, and just Google him. They've been read over 50 million times now, collectively. And it's some of the most cogent, simple to understand, non-scientific, but this guy is not a health professional, but science-based explanations of where we are and where we need to be. So this talks about South Korea's experience, where they had more cases than tests initially, but by early March, they flipped it. They flipped the ratio, and their new tests exceeded the number of positive cases, so that the number of positive cases were under 3%. That's the magic number. So this is an example from right now in New York City, where you can see they're testing broadly, and yet 22% of people have positive tests. So they're not testing broadly enough, and or it's out of control, that it's still, the fire is burning hot. There's too much COVID going on, and they're not at a place that it's safe to open up shelter in place or other things at this point. Now this contrasts to Santa Clara County, where we have just hit 3%. That means that as we test a lot of people, we are opening it up beyond just the symptomatic. We're testing a lot of people, and our PCR tests are coming back positive on average across the county around 3% of the time. That's great news. If we can keep it under 3% for 2 weeks, we should be in a much better place than we are today, than we were even earlier in mid-April, where you can see the rates were as high above 10%. So after testing capacity, which I hope you understand will be really important to follow, is something that we don't think about yet, is how effective are our interventions. It's very hard to say how effective our interventions are. And it's partly because each intervention has to be measured differently. Here's an example of mobility, right? How are people actually sheltering in place, staying at home? What this company did, Unicast, you can go to unicast.com, they've done is they've looked at cell phone data and GPS tracking data from cell phones across the nation. And they're looking at today's movements, how much are you moving around with your cell phone based on the GPS tracking, compared to historical rates for how much you move, and rated each state. So here you can see Nevada is doing pretty well. Hawaii is doing pretty well. People are actually sheltering in place much more than many other parts of the country. And this is just one example. We're going to have a whole slew of these come out over time. Obviously, this is one example that came out early. Google came out with their own version of this. And there's about 5 other mobility measuring websites out there. Happy to share some of those with you. The last thing I want to talk about in detail is the trace capacity. So let's say we're at 3% positive tests in Santa Clara County. Okay, are we good to open up? Are we ready to go back to business as usual? Are we able to open up non-essential businesses? Well, the next question is, what do we need to do is we need to track down every single positive case by calling people up and tracing all of their contacts. So this is an example of a website, testandtrace.com, which is trying to give a dashboard of where are there people, do we have enough tracers in California? Do we have enough tracers in New York compared to how many cases there are? Do we have the capacity both from testing and tracing to actually tamp down the disease and keep it down there? So I want to give you this, the importance of this is something that we have not yet talked about in the White House calls. We haven't as a society understood just how important tracing is going to be. Contact tracers are the last mile. They are people who actually go and make phone calls and ensure that every single positive case, let's say I go to Stanford's drive-through, get a positive PCR, then they follow back and go backwards and they interview me and say, who have I been in close contact with over the last 2 weeks? And then they call up each and every single one of those people and tell them to quarantine, right? That's what a tracer does. Now, how many tracers do we need in America? You'll hear numbers like 100,000 for America. That is the bare minimum, most optimistic, unrealistic number of contact tracers we need for the nation. And it assumes that we have everyone using apps that allow contact tracing to happen, that are opt-out, that are 90% used. It's unrealistic expectation, just like everything else we've heard. It's ultra optimistic. Reasonable estimates start to say we need something like 300,000 contact tracers across America. And if you look at what other countries are doing, like Wuhan in China, you can see they're much, much higher in terms of contact tracers per 100,000 population. So that's something that you should pause about and think about. We don't have enough tracers. We don't have good plans for it. And why do we need so many tracers? Well, it goes back to that R, that infectious statistic, that RT that I showed you early on, or R naught it's sometimes called. How many people do you need to follow up with? Well, if R naught is 2.5, you need at least 70% of contacts traced to get the R below 1. That means, let's say, we were in mid-April in Santa Clara County when we had an R naught of about 2.5. That means that I saw maybe 100 people in my last 2 weeks. Then you need to contact trace 70 people and put them in quarantine, effectively put 70 people in quarantine to get the R effective below 1. Yeah, that's sobering. In Taiwan, which has been among the most successful countries in the world, they never shut down. They kept their schools open. I think one school out of the whole country had to be shut down for 1 week. That's it. Otherwise, they continued mere 80 miles away from China with tens of thousands of people coming in from China and from America, trying to escape America, going back to Taiwan to stay safe. I know this because Jason Wang, a professor at Stanford, a friend of mine, is the one who's helping lead some of those initiatives. He told me that they have up to 300 contacts traced per positive case, up to 300. That's an army of people. We don't have that army anywhere in America today. And if we need to get down to an R naught of below 1 and keep it there and keep going downwards, that's what we need. We need armies of contact tracers. So when you think about tracing, you start by widely testing, number 1, top left. We're not doing that except for a few places. Our 3% is not there for most places in the country. Then you need to isolate those infected people. You need to find, number 3, everyone who's been in contact. That's the contact tracing. And then take all those people who are in close contact with that individual in number 2 and quarantine them for 14 days so that they don't lead to other cases. And repeat, that's the cycle of tracing. We have to box it in. This was by Tom Frieden, the former head of the CDC. And all of these references, every single thing will be available to you afterwards if you want to look at the full report. I'll skip over this slide, but you know about this. This is one of the better websites that keeps track of how many diagnostics are there in the pipeline, treatments, vaccines, and has much more data on that website. This is something I want to spend some time on. About 2 days ago, a group out of, I want to say Minnesota, came out with this report that talks about the various scenarios, looking at every single flu outbreak for the past 100 years, including the 1918 epidemic. And they conclude that our most likely scenario is going to be scenario 2. So that means in 2 weeks, you will see that second surge in Georgia and other states that have opened up. And then come fall, you will see a big peak. And then we'll have subsequent waves until eventually we get therapeutics and or vaccine and or herd immunity up to 60, 70%. That's the number they quote is 60 to 70% herd immunity to be effectively tamped down and protected from R not being greater than 1. So I've been Debbie Downer for quite a while. I don't mean to be so negative. I wanted to end on a positive note, so I'll talk about one of the bright spots. This is a Bay Area company that I serve as an advisor to. You may have seen it in a few articles in the New York Times in the last month about it. They sell smart thermometers. They have about 97% of the smart thermometers, basically thermometers with Bluetooth connections to your smartphone, and it uploads your temperature to the internet, to their servers. What they've been able to do is the CDC today is able to predict flu 3 weeks forward. So normal flu, CDC has a good job at a multi-state level of saying, what is flu gonna look like 3 weeks in the future? Kinsa has figured out how to predict flu at the county or sub-county level up to 20 weeks out in the future. So when you have a perfect picture of what flu is going to look like over the next month, 2 months or more in a given community, you can look at the actual fevers from 1 million smart thermometers across America. When people feel sick, they go to their medicine cabinet, they take out the thermometer, little Johnny has a fever, instantly gets uploaded. These fever clusters both spread within the family, before people get to work, before they become infectious to everyone else. That's the data that you're collecting. I looked at this data, this map in early March with the former head of the FDA and Dr. Wang, the head of the Taiwan response, and we thought this map was wrong. We saw lighting up in Texas and Florida in early March, and we knew there were no cases in February or in early March in Texas or Florida. And lo and behold, 2 weeks later, there were positive cases in Florida and Texas. And so what we don't have anywhere in the world today is a surveillance system, an early warning system that can tell us weeks in advance where are the positive cases before people get to the hospital. This is likely that signal. It's in people's homes, in people's medicine cabinets. Now we're going to distribute 450,000 of these thermometers across the state of California so we can get neighborhood level reports on fevers in real time. New York, Connecticut, and a bunch of other states and our neighbors to the north are also looking at this system. And our hope is that if we can get enough thermometers out there, we can identify hotspots, literally, in real time and put resources where they need to be as opposed to blanket orders across a state or across a county, both in terms of testing, tracing, and other resources to help catch COVID early in its phase of spreading. Why is this so important? Today, IHME website, which has been shown to be fatally flawed for many reasons, that relies on death data for the most part, that's a lagging indicator. By the time people die of COVID, it's too late. They've had it for maybe up to 2 weeks, by which time it's had 5 doubling periods, and there are 100 of cases left behind by the time of that death that are in the community over those 2 weeks. So as a lagging indicator and as an indicator that severely undercounts death from COVID, we know that from both US studies and international studies, the number of people dying from COVID without a positive test, dying at home or dying elsewhere, but without being attributed to COVID, is at least twice as much as what the official death counts suggest. So death is not a good number to follow when you're following COVID. It's too late and it's too small. Hospitalizations is a better number. When you have symptoms and you need oxygen and you get hospitalized, it's a much more leading indicator than deaths. But again, only people who feel sick enough show up to the hospital and get counted. And only half the states in America are reporting hospitalizations for COVID in the community on a daily basis. So to get an earlier indicator, such as febrile fever curves that subtract out what is normal flu and leave behind COVID, like this map, is really promising. And data suggests that, and I can share the New York Times pieces that go into more detail as well, that show when you're doing social distancing, it actually impacts fever curves in real time. When you close restaurants in Miami-Dade, ultimately the fever curve goes down. So these are real data from the healthweather.us website, and which is open for free to all public health as well to download the data in real time. So I'll stop there and we'll go to Q&A.
Wonderful. Thank you so much, Nirav. Really appreciate the wonderful presentation. Now we are going to try to get through as many questions as possible. So I'm going to directly dive in. I have a list of over 2 pages of questions that I got from our EPPIC members, and I want to try to get through as many of them. So let me ask the first one, Nirav. Among the 6 hardest countries lately, Spain, Italy, France, Germany, all have shown steep declining trajectories, whereas the US and UK remain on a painful plateau for 4 weeks. Is it due to late testing, late actions, or inadequate contact tracing?
So in the US, I think it's a combination of everything, all of the above, but there's an order to it too, right? We know that if health systems are overrun, as they were in New York, people will die who don't need to die. You know, I have friends from New York who talked about the conditions they had, and it was like MASH units. People were dying. If they just had oxygen, they would have lived. And that was the reality. So that was needless, preventable, and we didn't close down New York in time to prevent that. To flatten the curve, we knew you do social distancing, you will flatten the curve. We did a great job of that here, and as a result, we had plenty of capacity in all of our hospitals. I think there's 3 cases in the ICU with COVID at Stanford last week. 57 empty beds, something like that, right? So first was we didn't clamp down fast enough. Second is PPE, right? I mean, I'm a doctor. I'm going to the drive-through clinic. I'm swabbing people. I have more than enough PPE at Stanford. I'm happy to do that. I don't need to put my family at risk by doing my job. In New York, they put themselves at risk. That's not acceptable. It's not fair to ask people to be heroes. They'll do it, but that's not fair. And many healthcare workers have died and are continuing to die there. The next thing is testing capacity. We are nowhere near where we need to be, as I showed you, in testing capacity in most of this country, with very few exceptions. Santa Clara County, we've hit 3%, great. We're doing great here. The rich get richer and stay healthy. What about where all those nursing homes, right? It's those people who are dying like flies. And those vulnerable people in prisons, in nursing homes, in congregate living facilities are not getting tested adequately. And as a result, they're dying. So we know we're not doing enough from a testing capacity. And don't even get me started on tracing or anything else. So it's all of the above, but we have to start with testing. We do not have a national testing strategy. We do not have adequate testing capacity. The Abbott test, all of those are just dreams. They're not reality today. There are unlimited bad tests out there that give you the wrong information. And I've only talked about the PCR test. I haven't even gotten started on the serologic test, which is a Wild West. And I'm not even getting tested by those because they are so bad. The Stanford serologic study done last week, or reported last week widely, was fatally flawed because it had so many false positives, right? And you know, yes, bad tests lead to bad conclusions, which lead to bad policy.
Yes. But then the 3% number, how did you come up with, Nirav? I mean,
I didn't come up with that. There's a great explanation on why that 3% threshold matters. If you go to the Medium website and Google Thomas Puello, he has 3 articles there. The last one is on testing and tracing, and he has about 6 graphs on why we get to the 3% threshold. It's a very nice explanation.
yeah.
It's a long explanation.
Let me, I'm going to shift between people that are asking. I see Pushkar's question has gotten 8 likes. So why don't we go there? When 50% patients are asymptomatic, do they stay asymptomatic until free of infection, or do they result in mild or severe symptoms eventually?
So we talk about asymptomatic. That means asymptomatic from a health system perspective. That means they're not calling their doctor. They may have a slight cough. Oh, it's nothing, you know, it's allergy season. That's why I'm having my cough. So we actually don't know what the true definition of asymptomatic is. This is from a health system perspective of asymptomatic. And until we get all of those apps out there that are capturing all the symptoms in real time, that number may change. And yes, they do stay asymptomatic until free of infection, during which time they're spreading for those 2 weeks usually, or longer, sometimes as long as 6 weeks now I've seen.
Right. Let me go to the next question, Nirav. This is, I know you mentioned a lot of points, but if there were limited resources, then what would you say is the most important in saving lives? Is it the PPE, availability of diagnostic PCR testing, or guidance to doctors about treatment?
So there's no treatment right now, let's be clear. As much as we like to think of potential treatments from remdesivir and others, all of these are very marginal treatments. I will only count it as a treatment if it affects R naught. If it actually, you know, what we'll need is that multi-drug cocktail like we needed for HIV. No one drug as of now is a super drug, and they all have side effects. And they, you know, remdesivir is not an oral agent. You need to be IV to take it today. So there is no treatment that's effective. So going up further, what do we need? If we have limited resources, we have to start by testing. PPE, we're reusing it. There are now solutions on how do you take a mask and re-clean it and reuse it. So there are people who have plenty of PPE and people who have not enough PPE. That's a supply chain issue. It needs to be sorted out. I'm not saying we have enough for the country or for the next few waves, but we have enough relative to the problem of not enough testing.
Yes. So this very nicely segues into the topic of testing. And what we're going to do is we have separated into 4 different topics: testing, reopening, the disease itself, and treatment. Let's start with testing, because that is the most important thing. And you mentioned about several companies. We have now several companies marketing these tests, the virus as well as antibody. And you mentioned your opinion on the antibody tests. They have huge variability, even in those that have received an EUA from the FDA. So now as citizens, informed citizens, how do we make rapid sense and consistency in test deployment?
And that's one of the most common questions I'm getting as well. Like, which test should I get, doctor? Where should I go for it? You know, which one should I buy off the internet? Because you can buy a bunch of them now. And my answer is, we don't have a good answer, and that I would wait until you see peer-reviewed data. You know, everything is being put up in these test characteristics on the non-peer-reviewed pre-publication websites. And then when it gets peer-reviewed, the answer flips so many times. And so until we have peer-reviewed data suggesting that the sensitivity is X, the specificity is Y, and we believe in it, frankly, I believe more in some of the tests that are coming out of Germany that have been in use for thousands of people, that have clearly published guidelines and data around how good they are, over the ones that we're developing. I was talking to my brother yesterday, who's a neurologist, and he told me he has a test that he developed. He has no business developing one, and he's giving them out to friends. And I'm like, oh, please don't do that. But that's the state of affairs right now. It's a Wild West. If it was me, I'm not getting a test right now because I don't believe in it. And I'm going to stay at home and wear my masks when I go out, and wear my gloves and go out once a week, except until I know that R naught is down to a place where it's much better and that we have good tests out there in the next 2, 3, 4 weeks.
One of our members wanted to get antibody testing, contacted Stanford because she felt like she went through this during the December months. Are they available as a Bay Area native when you call Stanford? Are there?
Yeah. So let me ask you why you want to get tested. If you want to get tested,
donate plasma. This person wants to.
Okay, so that's a good reason. Because if you're saying, because I want to see if I'm safe and if I'm protected and I'm immune and I can go back and live with my family, that's not a good answer, because we don't know if you're actually going to get another viral strain of SARS-CoV, right? And so that's a good reason. Stanford does not offer it to the general public yet. I know they offer it to every single employee, and they're encouraging every single employee to get tested over the next week or two. My guess is that in the next week or two, as we are done testing ourselves, they will open it up to the broad public.
So as a public health, either the State Department, are they helping triage which are the correct tests to utilize for PCR, since you said that even PCR is at, I know we don't say companies, but Roche came out today with 100% specificity and 99.8% sensitivity.
And that's pretty good. I agree with you there. But I also know about other things that the FDA and higher than the FDA, a certain leader has done to mandate the FDA approve something straight from number one that had no evidence and that has set us back in many ways. And I'm not talking about the stuff that's in the news. I know of other things like that. So that's where I'm very skeptical. Unless I see the data myself, I can't recommend it.
Okay. Let me tell the audience, please go ahead and like any questions that you want to see answered. They move up in their ranking to the top. Right now, Ishita is at 5. I'm going to get to that when we go into the section of reopening, which actually is the next section. So why don't we start out with that question? And it's an interesting question that Ishita asked. Is the severe negative impact to economy and social and mental and physical health of people playing a factor in the decision making of when to reopen?
Absolutely, it's making a difference in the decision making. In a perfect world, you'd lock down like New Zealand has and eliminate the virus, because the last 2 or 3 cases, once everyone's gone down for 2 weeks, theoretically it should work its way out of the system. And that's worked in New Zealand. It's working in Hawaii. The reality is people need to get back to work. We don't have the safety nets that other countries have put in place. Today, you go to Taiwan, you need to be quarantined. They give you a nice place to stay. They give you all your meals, and they pay you if you get in quarantine. I mean, who's not going to take that? Yeah, I'll take time off and get paid and have you're a nice hotel with free video and free, absolutely. Whereas here, good luck, you're on your own and you're not getting paid. And by the way, the 30 million Americans who now have filed for have lost their jobs are now going to be without health insurance soon too. And we don't have a safety net for them today. So yes, that's absolutely playing a role. My problem with this is it's made as it's a false choice between lives and livelihoods. It should be both. We have to prioritize lives and livelihoods, and it's in that order. And by jumping around, what we'll see is a second wave very soon in Georgia and elsewhere.
Yeah. Let me ask somebody who asked a question before. A lot of states are opening up, Texas, Michigan, even beaches in LA. You covered this. Will there be a second wave because of these premature openings and unguided, clear, staged openings?
Well, I don't believe in magical thinking. And if you look everywhere else in the world as our best guide of what's working and what's not, in Japan, I forget the town, they opened up a little too quickly in the north and in one of their islands, and they saw a resurgence very fast. So wait 2 weeks and see what happens in Georgia. The governor of Georgia has clearly stated that he is never going back, that he's going to stay open no matter what. Let's see what happens in 2 weeks. Be evidence-based, based on other countries' experience. The only thing that works is broad scale testing, tracing, quarantine, isolation, until we have a vaccine or drugs. It's all about our not.
Indeed, indeed. Let me go back to testing. Nilima asks, and this is an interesting question. Korea had said that, a person who tested positive, can they get COVID again, reinfection? And would love to see if you can answer that question. Was that a false positive?
Yeah, so we don't know. The answer is we don't know, but we think it's false positive, that initial test was probably incorrect. It falsely concluded that this person's positive when they weren't. That's the best guess right now. We don't know. If it works like other SARS and other viruses, theoretically, it shouldn't. But that doesn't mean that strains haven't changed over time. This virus is evolving, and we don't know one test versus another. What are they testing in one test? What parts of the virus are they testing in another? All of those things play. So it's too early to say. Our best guess is possibly you will be protected after being infected, at least for a few months. That's the best guess as of today.
Yeah. Since we are on reopening, but we have heard a lot that we need 2 million tests daily. You have also mentioned a lot are needed. From a public system perspective, new companies are coming up with tests. Roche came up, as you said, Abbott has tests, and several others. What is the volume of this test? Are we concatenating that? Are we going to reach that 2 million tests? Or is this going to be the new normal of some stay in place forever until we for this ramp up?
So what you've seen in the ramp up in the last month has been us stealing our reagents from our research partners and others to try to get the ramp up to happen. It's not been true growth in testing capacity as much as it has been mostly borrowing, begging, and stealing from other parts of the system that already existed. The hope is that with Abbott and others, that we will create actual new capacity, new real testing capacity that's much more substantial. Now remember, none of this is centrally organized. None of this is coordinated. A lot of this is questionable in its reliability. And so you be the judge. I mean, what I think, I would be glad to see us have plenty of testing capacity over the next month. I'm not going to hold my breath. You'll see the 3%. You'll see what the percent positivity rate is. That's going to be a good indicator of how good we're doing, and follow that closely.
So next question is, states are making their own decisions, right? And you're seeing that. Should there be a federal mandate, Nirav, or keeping these decisions at state levels with, say, a guidance like the 3 that you have criteria in your website? Is that appropriate? Or is there a one side? What is your suggestion? Keep between state and federal mandates?
Yeah, what keeps me up at night and what I worry about is that a casualty of this pandemic is American leadership. Leadership is never more apparent than when it's missing. And we know from this virus that we are as strong as our weakest neighbor. Today, Santa Clara is fine. Tomorrow, someone comes from the next county over and we've opened up because we've tamped it down. We're back to where we started. All it takes is one person to infect 50 people and you're back to where you started. So there's no rational reason to approach this state by state. That's why multi-states are connecting together, the Western states, the Eastern, Northeastern states. I'm hoping that someday maybe we can actually get back together as one United States, because otherwise we're not going to win.
But as a part of that committee, as being tuned with White House, are you able to influence states to go one way or the other? I know states have their individual issues with the constituents also. Are you able to communicate the reasoning and the science?
One of the groups that I'm a part of is this group of all of the health commissioners of every state. And so I talk to them every week. I talk to them just Thursday. and politics trumps everything else in many states. In Georgia, in Iowa, in other states, it's not about the science. It's about the economy. It's about getting back to business. It's about the protests that they're seeing, and they feel like they have to open up to give people their jobs back. And this is the biggest intergenerational wealth transfer we've ever had, from the young to the old, right? If you think about it that way, 30 and younger, you're probably going to be all right for the most part, unless you get a high viral load and otherwise. And if you're 65 and over, it's very dangerous for you. So the broader thought is, what is our society going to look like? Is it going to be a bunch of people who are stuck at home until there's a vaccine, while parts of the economy go back to work? I think so.
What do you think, this last question on reopening, and then we'll move to disease. What do you think of Governor Newsom's? He is being proactively talking about staged opening. California presented. Do you think that is reasonable? Does it jive with the criteria, scientifically driven criteria?
Yeah. I think it does. I think he did a very good job. I think both he and Cuomo have done a really good job communicating, better than just about everyone else, and sticking to the science. In terms of the specifics of his plan, why are rock pools and tidal pools open, and why is singles table tennis allowed? That's just bureaucrats doing what they do. You shouldn't worry about that. The broader plan is much more thoughtful. It's fantastic. Much more measured. And I think that what I've also seen him and the state do is they react in real time to data, and they change their mind. They will change according to the circumstances. If the data suggests we have to go backwards, we'll go backwards, right? So I'm very optimistic that we're in the right place.
Yes, I know we have 31 questions pending. Let me go to Ravi's question. Ravi Srinivasan, he has 8 likes. Given we are moving into the disease part now. Given the very low rates of patients that recover who go on ventilators, is there a rationale and case for not using it at all unless in extreme situations? Is there an emerging concern?
Great question. And that's what physicians are talking about right now. My friends in New York who are in the ICU were saying, we did everything that was possible to keep someone off of the ventilator, and then we did even more. Like, they needed it and we kept them off it. And once or twice when we pulled that off, we knew they would live. So the guidelines are changing as we speak. There are components of the ventilator need that is different from SARS in the past, whether it's blood clots in young people. And so, yes, the guidelines are changing in real time. A lot of doctors are discussing this on Facebook groups and others on what they're doing to keep people only on oxygen, away from the actual ventilatory support. Though, those who need it, if you need it, it's not 100% mortality with ventilators. The 20, 30, 40, 50%, depending on where you look, can survive and come off a ventilator.
Yes, yes. And we are understanding more about these coagulopathies also, and the silent hypoxia that goes on. Pushkar asks about herd immunity. Where does it come from? Is it just, and can you help understand herd immunity? You said 75% number, but help our audience understand herd immunity.
So herd immunity means how much does the virus bounce around? Let's say the virus, you will, let's say I will touch 10 people with while I'm infective. If 7 of those people are already immune because they've been either vaccinated or they've recovered, and on average, I infect 2 people, what are the probability of me growing the disease versus the disease going down? That's what herd immunity is about, is that if there's only 1 person who's immune, my 2 people are going to spread the disease. If 9 people are immune, what is the chance of me hitting that 1 person who's not? Very small. Herd immunity is all about, let's get as many people out there who will not spread the disease, so that the virus has less chance of bouncing and actually infecting the next person and going on and on and on.
That's a very good question. And we are not there, right? We are not even close.
Not even, I mean, if you please, we're in single digits.
Yes. You know, the next question goes into the disease itself, the virus. Will the high mutation rates of the virus make it difficult to develop an effective vaccine? Could the mutations lead to a more virulent strain?
It could, and we don't know yet. It's too early to tell. What's unusual about this virus is that it's got a high R naught, and it has a high mortality, and it has a high latency period, and it has a high percent of people who are asymptomatic. That combination is what made this so bad, right? Other viruses, Ebola and others, you know, you could have a bad disease, but it has a very low R naught, right? Or, but to have both high R naught and it does something very bad to you, that's very rare. That's what we're seeing now. Our hope is that with mutations, maybe it won't have that same double punch combination. Maybe it'll still be highly infective, but it won't kill people, or it'll be very mild, something like that, right? So we don't know. All of this is speculation. As treatments come out, we'll see how the virus changes. Right now, there are lots of different variations, but they don't seem to be that meaningfully different, one strain versus another versus another.
Yeah. Let's take a question from Ramani. Any thoughts on the Sweden versus Norway experience?
I think it's too early to tell. And I think it's, you know, obviously you know what you're talking about and you're following the story very closely. One country, I don't make up my mind based on one country. I make up my mind on the fact that Germany and South Korea and Taiwan and, you know, are all testing broadly to determine that, yes, we absolutely must need broad testing. You know, if you open up your economy, you get lucky, who knows? I'm not going to make up my mind or speculate on one country.
Great, great. Hey, you know, this is a very little scientific question. You know, IFR versus CFR. Do you see IFR as a more impactful factor? It is harder to measure versus CFR, and if so, what's the impact?
So IFR and CFR is getting into the weeds a little, but I'll show you a slide based on that. So where are we with IFR versus CFR? What is CFR? CFR is the case fatality rate versus the infection fatality rate. So here, the case fatality rate are those people in orange, right? How many people are we actually seeing in our system versus how many people who are not hitting our system for some reason? Ideally, if we're testing very broadly and that 3% barrier I talked about, we get below 3%, then the CFR and the IFR are the same. When we're testing very few people, the CFR and the IFR can be very different. So yeah, I mean, it's a technical term. You'll see people throw them around interchangeably. I wouldn't worry so much about them. Focus more on the RT and the fact that we're actually testing down to 3%.
Good explanation. Let's go to Vikram's question. And then this is on the minds of many people. You know, there's a wide spectrum of outcomes, whether it is cities or individuals. What is the current view on some of these people that such a differential effect on severe symptoms versus a benign course of disease?
One of the things that I've heard with interest that is not supported by the data yet is it's related to stress and how much viral load you get at the beginning, right? Lots of young residents, very healthy, 27, 25 years old, are dying in New York City's hospitals because they're working night and day, and I suspect are being exposed with a high viral load. We haven't seen young people die elsewhere like this. So that's one of the theories on why we're seeing such differences. And of course, we know the strains have something to do with it as well. People speculate that the strain that is in New York came mostly from Europe, from Italy, from those sides, whereas the strains we're seeing here came from Asia directly. And so they have a different rate among the different environments as well. So again, all of this is very early. I wouldn't bank on any of that right now.
Okay. You know, one question is, over the past 2 months, our doctors have treated so many patients, especially in the US, they've seen it. We have an improved understanding of the symptoms of the disease. We don't have treatment. Over these past 2 months, the learnings, have they improved care and fatality rates that we are seeing because of a better understanding at the clinical bedside?
I wish it were true. I can tell you that I've, 3 days ago, the CDC updated their symptom list on what counts as symptoms for COVID. They added a whole bunch of symptoms that we all knew long ago, right? How has it changed? Well, what has changed is, and as I do video visits at Stanford for COVID, I get the same list of all of the symptoms that I had 3 weeks ago, that I had 2 weeks ago, that I had last week. What's changed is 3 weeks ago, I'm like, okay, I think you have COVID. You've lost your sense of smell. You've lost your, stay at home, self-isolate, self-quarantine. Good luck with that. And come in when you can't breathe. That was my advice. Now, thank goodness I can say, please come in and get tested, because we finally have enough tests. So what's changed is the number of tests. It's still not enough, but it's much more than we were even 3 weeks ago in this county. So it hasn't changed fatality.
Yeah, let's go to this question, which Ramani asked as well as Hemant asked me. Oh, it's any insight on why New York, New Jersey has really unprecedented infections, whereas if you compare Bay Area, between December 1 and Jan 23rd Wuhan lockdown, close to 300,000 travelers may have arrived in San Francisco directly from flight from Wuhan. Why that difference? I mean, New York is crowded, understandable, but there are other cities that are crowded too.
That's right. And part of it, what may be due to the strain of the virus that we talked about, Italy, is what seems many travelers came from Italy to New York, New Jersey. And that's a slightly different strain than the ones that we saw here on this coast from Asia. But also, there was a difference of about a week and a half to 2 weeks in terms of how fast we locked down. That 2 weeks made a huge difference. And the books that will be written will show just how many lives were lost by that delay in New York, New Jersey.
Wow.
Yeah. I mean, you can do the math, right? If a doubling period is 2.5 days, right?
Yes.
4 or 5 doubling periods makes a big difference.
Yes.
And then add in the density and other things.
Let's go to something that is near and dear to us. India, you mentioned that India downloaded your model. How can you explain India's low infection rate? And Yash also asked this question here online. If the virus is so contact driven, that's one question. And another question that was asked by someone is, how, in your opinion, India will fare in general through this virus spread?
This is a tough one. So, other folks have talked about how with seasonal flu, for example, with normal flu that comes every year, it bounces from the northern hemisphere to the southern hemisphere and bounces back and forth, right? So all those strains, and so that's why our flu season is generally from the fall to March, April, May. When it gets warm again, it's still there, but it goes away for the most part. Why? Because the R naught goes from just over 1 to just under 1. So the social, when people are outside of crowded homes, when people are out in the community, with the temperature, the humidity, all of those changes makes just enough of a difference to go past 1 with that RT, with normal flu. Now, with this one, with SARS, with this COVID-19, if you're at 2.5, maybe with summertime, it'll go from 2.5 to 2.4 or 2.3. It's not going to make a difference. On the other hand, if we've done everything else to bring it to 1.1 and it becomes 0.9, then it starts to decline. So that we don't know how much all of our masking, all of our hand washing, all of these different interventions we're doing simultaneously is really bringing down the R naught. We have really good guesses, right? But we don't know. And so that's why India may be different, because I know my family in Bombay, not all of their servants went back home to the villages. They're doing everything on their own. They're not allowed to get groceries. They're not allowed to do anything. And they're really locked down.
But they are doing tremendous contact tracing.
Yeah.
I mean,
they have armies of that.
Armies of that, yeah. Every hospital, Kasturba.
So that's the problem. I think India is unknown. It's a big unknown.
Okay. All right. Fair enough. Let me go to Rajiv Dolakia's question. He brings a very interesting question. Since COVID-19 will be here with us for a while, is there a reliable personal risk calculator? Interesting. Based on mortality, understand that our conditions, higher risk. Is there an insight on genetics? A lot of is bundling into that question, but any insights?
I hope you make one and share it with me. We're trying to do that modeling right now at Stanford with as many different variables as possible. Doing a lit search literally every day on all of the new materials that are being published, not only in peer-reviewed journals, but newspapers, everything. We're summing it up, trying to understand what does air pollution, what does, every factor lead to that kind of a model. But my personal guess is a few variables are going to make all the difference. And so at an individual level, figure out what your county has, how good is shelter in place working, what is the RT for that community that you're in. I would frankly go play golf now because we've done pretty well here. And if you're only allowed, and they don't have holes anymore where your ball can drop, it apparently bounces off a stick, go play golf if you're in Santa Clara County. Those kinds of things you should do at a personal level. I'm telling my relatives to do that, even though they're older and have multiple conditions, because in the grand scheme of things, they're probably all right.
Yes. Let me tell the audience, there are 35 outstanding questions.
Oh my gosh.
Please go and like them, because the ones that you like and you want answered will boil to the top and we'll address in the last 5 to 10 minutes.
And I'll do lightning answers now. I won't go on and on.
Sure. How's COVID-19 impacting cancer patients? That was one question.
Not as much as you think. The one problem has been delayed in surgeries, but now they're rapidly those people are getting priority to get non-emergent surgeries done, to get cancer surgeries up and running. But remember, cancer patients already were on lockdown on their own because of immunocompromise. They already had PPE and other things.
Yes, yes. Let's move to the treatment section. Antivirals, you mentioned about remdesivir data was not as powerful as a single agent. Do you think we'll need a cocktail of antivirals to get this viral load down?
Well, David Ho is one of the smartest people I know, and he was one of the founders of all the HIV meds 30, 40 years ago. He was one of the people who says that he thinks that it will require a multi-drug cocktail. And the problem is today's multi-drug cocktail, azithro plus remdesivir plus has multi-side effects, and the side effects are much greater than the effects. So I don't believe in any treatment today unless you're in the hospital, in the ICU, then maybe you get some remdesivir.
Yeah. Also, they were talking of low oxygen levels monitoring by pulse oximeter. Is that something that you're going to see in the clinics or even at home?
We do that in our drive-through clinics. Because people may not be totally cognizant of their symptoms. As they're getting tested with a PCR test, we're just putting a pulse ox on them right then too. If they're below normal, then we send them over to the hospital for further checkup. Yes.
Okay. Let me take Padma Channa's question. Once tested positive, a patient at the hospital, how many times do you have to test before the person is negative? I'm presuming as they get better.
Yeah, and so with the PCR test, we usually wait a week or so and then retest them. There's no good guidelines yet on how frequently or how based on symptoms, but you want them to be feeling better and have a few days out before you retest them, because we don't have enough tests as a nation. We've been doing that with a lot of patients. And we test every patient before they get admitted to the hospital, even if they're going in for cancer, for some surgery, for something else, just to make sure that they're negative before they go in for elective surgeries or elective procedures right now.
Aparna asks a good question. We talk about the death, those that die, but what are the long-term effects of the coronavirus on those that survive?
So a lot of reports are coming out now about it's not life as usual, that there's people who've been on ventilators have long-term side effects, including ventilator brain, or it's known by some other things. People who have been, they're not 100% normal, and we don't have a good picture of what or why or who suffers from these negative side effects of having had COVID. COVID attacks many different parts of the body through the ACE inhibitor. And so we don't understand. Some people have a GI, some people have a brain, some people have a pulmonary, some people have other symptoms. We do not know the answer. We know that it's not 100%, and that's an evolving field.
Sunita asks us, very good question. Is there a severe undercount of ethnic communities, many of whom have little or no access to healthcare in our counts?
Absolutely. Every hyphenated American is undercounted. We know from testing in Pine Street homeless shelter in Boston, literally 37% of homeless people without symptoms, everyone had no symptoms, 37% tested positive. That's crazy. So anywhere you look, crowded, multi-generational families, underserved, poor access to healthcare, we know those are the places that are going to harbor COVID in the community because they don't have access to care.
So then how do we address the undercount, she asks again.
And that's the problem, is we are as strong as our weakest neighbors here, right? If you don't make the point of testing every homeless person in San Francisco, what's to say that it's not going to live under that bridge and then reinfect you 2 weeks later when you're entering a building, right? Those are the things that we as a society have to figure out. And if we don't, it's at our peril.
So, well, how are the ER physicians that are currently seeing these patients keeping abreast of this knowledge that is changing every day?
So I wouldn't think, I mean, ER is a front line in one sense, but their job is easy. They just, I'm sorry, I'm an internist, so I'll make fun of every other kind of doctor, but they have to basically decide, does the patient get admitted or can they go home, right? That's the only decision.
So maybe the question is re-answered for internists. How?
Yeah, and so there are lots of strong communities with standard guidelines coming out all the time, being updated in real time. Every time I go in and type a note for a patient, the standard guidance automatically populates my notes and it's been updated. I'm like, oh, I didn't realize that. Well, look, now I have to ask these 3 other questions that I didn't know I had to ask. So that's happening with electronic decision support, with guidelines, and certainly the people in the community are getting the information in real time. That's actually one of the bright spots. Unlike everyone else, what we as scientists have done with this COVID epidemic is share broadly. It's not about credit, it's about doing good. And whether it's the vaccine research, whether it's the basic science, whether it's clinical care, everyone is sharing without need for credit or payment as much as broadly as possible. That's a bright spot.
Indeed. Let me ask you a last question on the treatment side. You know, there are a lot of vaccines, sorry, not treatment, but vaccine, RNA vaccines, DNA vaccines, viral vectors, live attenuated. In your opinion, which type of vaccine you feel is most likely to succeed, if you believe one would, based on experiences on the SARS-CoV-1 and MERS-CoV?
Yeah, so you know, it's been what, 30 years, we're still waiting for a vaccine for HIV, right? So I'm not holding my breath. As much as I'd like to say that we now have monkeys being tested in UK and rhesus monkeys, oh, it's working really well. There are 3 or 4 that are further in the lead than others. Until it works in humans, don't buy stock, don't make bets, wait.
Well, this has been an absolutely wonderful session. I feel disheartened with 33 unanswered questions, but a lot of those you did cover in your discussion. Thank you so much for your time. Any final words, Nirav, on
Thank you, Sanjeev.
We as informed citizens can do to help science data lead us as we go through this on the clinical as well as economic side?
Yeah, I'll end with a quote from Lee Kuan Yew, was the president of Singapore, who turned Singapore from a third world nation into a first world country in a generation. Science-based, brilliant man. And he said that there is a continual need to balance between a successful, competitive society and a cohesive, compassionate one. Oh. We need to focus on that cohesive, compassionate side of things for the while. Thank you, everyone. It was a real pleasure.
It has been an absolutely wonderful session. I know we didn't see the faces of everybody that joined in. Robert, I'm going to call it, hand it over to you. Again, thank you so much, Nirav, for an excellent session, presentation as well as a Q&A session.
My pleasure. Thank you. Bye.
Folks, Robert, go over a little bit on the EPPIC background. Robert, over to you.
All right, great. So thanks so much, Sanjeev, and thanks for Nirav. Perfect. So folks, I know it's Sunday afternoon and it's getting on nearly dinner time. So I appreciate you hanging out for 10 more minutes to listen to some updates on EPPIC itself. Hopefully everyone's doing well and healthy. As you can see, my quarantine beard is certainly nice and healthy. I hope you're likewise. So look, a couple quick slides here on EPPIC, and there's about 10 minutes, right? So my name is Robert DeFeo. I'm the president of EPPIC Global. I represent a great team of executive committee members that are working hard to provide this content today, and are going to be working hard to provide you with a lot more content in the near future. So I just want to cover a couple of quick things with you, just to give you a sense of what we're up to and what our plans are here in the upcoming few months. So I'll cover just briefly our value model, as well as what it means to become a member of EPPIC and how to join us. So firstly, EPPIC is where technology meets healthcare, right? We mentioned that up front. That's the theme, and that's where we're focusing. At the same time, we don't provide physical goods. So what exactly are we providing? And really, our value comes from us. It's our member base, and collectively, we are able to get together and provide these type of talks in a way that few other places can. It's hard to find areas that can go to the depth that we can in such a range of healthcare domains. So really, the combination of expertise as well as connections within a diverse set of healthcare domains is number one. We also have a deep passion for learning and sharing our perspectives within healthcare. And through that comes mentorship. And collectively, between the executive committee and the board, we have successes across early, mid, and late stage career, which gives us a great potential to mentor a wide range of people within a wide variety of healthcare domains. So just for, this list is not all encompassing, but those of us who are currently part of EPPIC are entrepreneurs, physicians, students, engineers, investors, lawyers, business consultants. We run the range of people that you can imagine being involved within healthcare. And we pull all that together and provide you content and provide you opportunities for networking as well as mentorship. But to be a bit more specific, right? What specifically are we angling to offer you today and then the near future? So it's really three high-level areas. Number one, specialized content and programming. So as you can see today, this is a great example of that. Clearly with COVID-19, in the past, we would have done many in-person events. So at the moment, we're not doing those, but certainly we'll get back to doing that when time allows. But then on top of that, network access. And look, network access will come just through these events in some fashion, but also we're looking to provide more clear, actual, angled type of content for network access explicitly. And then mentorship as well. I mean, mentorship comes in some fashion just through attending these events, but again, we're working to actually provide a more clear, structured path for mentorship as well. So these are the three areas. Who's our target audience? Well, it's everyone who we just mentioned up above, right? But I would say that in general, the target audience is going to be a higher level professional group in terms of entrepreneurs, professionals currently in healthcare and not in healthcare who are, say, at a later stage in career, as well as mid and entry level, and then also even students. And as such, we have a segmented member groups. So as you can see here, we have 4 member types that we're offering. There's a charter membership at a rate of $500 per year, an entrepreneur member as a rate of $200 per year, professional and student at a $150 per year rate, okay? So these 4 areas, we're looking to provide segmented content to be angled explicitly towards these different member types, as well as network access and member that's gonna, as well as mentorship that'll add value specifically to these 4 membership types, okay? So this is what we're up to. This is what we're providing. Now, how are we doing it, and what do we plan to do in the near future? So before I go into that, I just want to explain, high level what our thought process is and how we're planning to get there. So we have a goal, and our goal is to be a leading forum for healthcare and life sciences with a focus on where technology meets healthcare. With that goal in mind, we formulated our strategic positioning. We've correlated that to core pillars, enabling pillars. We have a comprehensive strategic plan. Through that, we've identified a clear organizational structure, and at this point now assembled an actual operating plan for the next year. So where we are today is we have an operating plan, and we're in the middle of executing on that. And as you can see, today's event is part of that execution. And as we continue to host these events and get more members, we'll learn and we'll scale. And so we'll be in this sort of positive feedback loop between our operating plan and execution mode in the near term. So how to get involved, right? So I can tell you, without going into too much detail on our strategic plan, we are certainly aiming for significant growth. So by becoming a member today, number one, from a content perspective, you're guaranteeing yourself access to all our upcoming specialized content, as well as access to prior content. Only members are going to be provided access to, say, recordings like what you're seeing today. Also, as part of being a member, you'll have access to more of our more visibility within our organization, right? So what are our strategies more explicitly? And also have ownership over them. And as part of that, you'll have direct access to working with our executive committee if interested. So what's upcoming, right? So in where we are today, Q2 2020, we're in the process of setting up our communications and our finance platform. So we're developing a lot of infrastructure internally to really make sure we're prepared to scale as we intend to. Clearly, also, we're putting on webinars like what you see today. And through this process, we intend to learn and get members and build on that foundation. Where we anticipate then in Q3 really ramping up. So in Q3, we intend to launch more formal programming structure, clearly in specialized content how we are today, but also in areas of networking and mentorship to complement that full value model as we described in the previous slide. And then as we move into 21, apply those learnings and continue to scale. So I'm sure this is all super exciting and you're asking yourself, how do I get involved? Well, fortunately for you, there are 3 openings we have right now as part of the EC. And so the executive committee is who really put on these events, who coordinate, getting the webinar set up, the surveys, the emails you all have seen, the marketing on LinkedIn, etc. And the 3 roles we need today, okay, so somebody with website development or IT skills, someone to help manage our email segmentation and distribution, as well as be a lead on webinars. We intend to scale this webinar platform and need someone to help really manage that. What I will say is, look, I'm certainly not, don't come from a tech background. And so what I will say is don't be intimidated if you don't have prior experience. What we need is someone who is passionate, who has the same passion for healthcare as we do, and wants to get involved and wants to put in their time, right? And we fill in the gaps from there. So if you're interested, and this email will be distributed after this meeting, but just for reference, if you're interested in being part of the EC, take down this note, take a screenshot, epicglobal@gmail.com. We check it regularly, and we'll certainly communicate through that platform if you're interested in being part of the EC. Okay, so with that, I just want to say thank you very much. Okay, on behalf of the global EPPIC Global Network, Amita as the chairman, certainly Sanjeev as a moderator from today, and Nirav, but also the EC overall, right? As you can see, we have a dozen members on the EC. We have another 10 as part of the board, and certainly today's effort would not have been possible without everyone chipping in, right? So my thanks to all people who are involved in setting up today's event. My thanks to everyone who attended the event. And become a member, right? As you can see here, this is our link. Through this link, you're able to sign up for the different membership categories that I discussed before. And also, if you're interested in being part of the EC, email myself and the rest of the EC at this address here. Also, we're on all the social media platforms now. So if you're interested in hearing more about us, please follow us. And through that, you'll be part of all the upcoming distributions. So what we're going to do after this, just so you're aware, everyone who's part of the who registered today will be getting an email. I would really appreciate if you can respond to that. We have a survey just to give you some opportunity to provide feedback to us, and also a link to become a member. So with that, I think we'll close at the meeting. Sanjeev, I see you coming off mute there. Okay, so with that, thank you very much, everyone. Hope you had a great, enjoyed today's session. Hope you had a great rest of your Sunday, and hope to talk to you soon.